every 40 seconds somebody has a heart attack. If you don't want to be one of those people, then listen up. I'm Dr. Twyman, I'm a board-certified cardiologist. I focus on the early detection of vascular disease and help people not have heart attacks. So this is my Makeup AMA session from Monday night. Usually I do those every Monday, 6 p.m. Central Time. But I was recently traveling to a business event in Las Vegas. I was at the Hormozi Scaling event, which is going to help me get Apollo Cardiology to more people and help more people reduce the risk of having a heart attack. So it was an outstanding event. Just got back in town late last night, getting caught up on my circadian rhythm management. I do have the questions from the other night that were submitted, so thank you. We're going to answer those. And then I know a few other people had put in some of the questions today. I'll answer those as well. So this podcast that I did recently was about reviewing my own labs. I have gotten many comments about that. It's one of the things that they wanted to see more about. So I recently put my interpretation of one of my most recent lab reports up on my YouTube channel. So it's just drtwyman.tv. That's where my more long-form videos, my education content's can really start living. That's really something I got instructed at the scaling event to really focus on YouTube to be able to reach more people, to be able to help more people. So still going to always be doing these IG Lives every Monday night, 6 p.m. Central Time normally. This is the makeup one. But if you want any more long-form content, start following me on YouTube, just my name.tv. So we'll get started with some of the questions. First question up today. Person says they have a high ApoB of 126. That's definitely going to be above the 80th percentile. And they also have high oxidized LDL, so modified damaged cholesterol. Quote, good blood pressure and a calcium score of 0. Will lifestyle changes work here? Well, I don't know if the question is, will it work alone? Probably not. Is the default answer. I mean, it's always good to be doing those things. To be metabolically flexible, to be aerobically fit, to manage your stress and sleep well. That'll help with reducing risk of cancer, Alzheimer's, diabetes, but it may not have enough effect on lowering ApoB by itself. So calcium score 0 is a good start, but I generally prefer the clearly CT angiogram to look for soft plaque, because just the calcium score of 0 doesn't indicate that you don't have soft plaque in your arteries. I do a lot of testing at Apollo on my practice that looks at endothelial function, looks at inflammation in the arterial lining. So there's other testing you can do to see are your arteries truly healthy with that. But if your ApoB cannot get controlled with lifestyle alone, then you can use different nutraceuticals and pharmaceuticals to try to get you to goal. Most people should probably be shooting for an ApoB of less than 70. Next question of today, what are my thoughts on Urolithin A, benefits of taking risk? So don't think there's any major risk. Benefits are that it helps with mitochondrial function. I think you can actually try to kind of mitochondrial biogenesis, so grow new mitochondria. Good product, lots of interesting research. The only downside is really the cost. I haven't looked at it recently, but I think it's probably somewhere in the 80 to 100 US dollars a month to take. So if finances aren't a major concern, it's a interesting thing to add to the supplement stack. But if money is a concern, there's lower hanging fruit to focus on first. The next question. Must you get labs and tests that are potentially, what tester must-haves for a potentially actionable person who's a 54-year-old male? So I always recommend doing some combination of biophysical and biochemical. So the biophysicals, how healthy are the arteries? So I do testing that looks at endothelial function. If you have access to it, that would be an endopat scan. Pulse wave velocity testing also is a good surrogate for vascular health, but not as sensitive as an endopat. Blood pressure should be less than 120/80. Carotid intimal medial thickness scans, which gives you vascular age, also looks for vascular inflammation, and any soft plaque or hard plaque in your carotid arteries. And then the standard is if you're over 40 and have not had a heart attack, stroke, stents, or bypass, then I would get a CT coronary calcium score or a clearly CT angiogram if you have access to it. And then the biochemical, there's a whole host of labs. Usually break it down to 3 buckets. Test to look at nitric oxide availability, test to look at inflammation, and test to look at lipoproteins. Next question, do I take patients from out of state, Arizona to be specific, which is actually in Arizona a couple weeks ago at the Canyon Ranch. Outstanding place to recharge your mitochondria. If you ever have access to it, I highly recommend. So my practice, Apollo Cardiology, is located in St. Louis. Currently, because of medical licensing laws, I do have to see the patient live the first time to establish a patient-physician relationship. and then after that can do some telemedicine with them for the next 12 months or so. So first visits are always in St. Louis, follow-up visits can be done remote. Second question, is 5 milligrams Cialis a day appropriate for a 50-year-old, quote, healthy patient for cardiovascular benefits? I would say, likely, but there's not a lot of studies on this. The Cialis is a phosphodiesterase inhibitor. It blocks the enzymes that degrade nitric oxide, so it keeps nitric oxide around longer to help dilate arteries, keep things from sticking to the arteries. So potentially beneficial. So the only concern really is that, is it going to be covered, from an insurance standpoint? Probably not for that indication, but if it's something that isn't a financially struggle for somebody, I think it's a reasonable option, but you also want to work on filling the funnel with nitric oxide by exercising, getting the right types of green leafy vegetables, spinach, arugula, kale, probably the biggest three. Swiss chard's another. Beets can be also an option for some people. And then sunlight exposure, UVA light striking your skin, liberates nitric oxide. Don't break nitric oxide pathways by using mouthwash or acid blocking medications. So start with building nitric oxide up so that the medication Cialis would be able to keep it around longer. This is why some people don't respond well to those medicines. They don't have any nitric oxide to keep around. Person says, time to get a new PCP or cardiologist if they don't ever check ApoB on routine blood work? Possibly. I mean, if your doctor's, curious and can work with you, then not necessarily. But if they're dismissive of your concerns, or you, say, hey, I'm really interested in getting ApoB checked because it's more sensitive at looking at vascular risk than just LDL-C, and they're not responsive to that, then yes, probably would look for somebody different then. Next question, does intense exercise decrease LDL particle number? I have not seen that in my experience. The exercise is great for other reasons, but I haven't seen it have a dramatic effect on LDL particle number by itself. Next question, is there any correlation between cardiovascular health and mood swings or depression? Yes, patients who have myocardial infarctions and have depression have worse outcomes. They die sooner. So there definitely is a link. Exercise, does help a lot of people's mood, so that would potentially be beneficial. Preferably you're exercising outside and getting full spectrum sun into your eyes and on your skin. That's going to help as well. You want the compound POMC to be produced to create beta endorphins. So this is definitely a link that you should look at. All right, so let's see, I got some more questions coming up here. Question, does the venous system have an impact on CVD? Well, depends on what you mean by impact, but does venous insufficiency have an effect on coronary artery disease? No. Is venous insufficiency a type of cardiovascular disease? Technically. So it really depends on the question per se, but just having a venous issue does not necessarily mean you have an arterial issue. Next question up. What is the ideal distance for red light panels from the body? Is closest to the body better? This is a very tricky question. The studies were mostly done with contact. Panels that are further away from the skin, less are getting photonic energy into the system. So you first need to know what wavelengths of light you're dealing with. You need to know the irradiance or the power density of the device, so that's measured in milliwatts per centimeter squared, and you need to know the time that you're going to be in front of the device to get the dose. This is why there's not a specific recommendation. It depends on those three factors. But closer generally is better, but some devices have a lot of EMFs coming off them, so that's why many of the manufacturers can recommend that you're at least 6 inches away from the device. So my preference is that people acquire devices that are DC electric powered so that they can actually have direct skin contact. But if they're using a panel that's plugged in and has EMFs, then you need to follow the manufacturer's recommendations on how far to be away from the device that you then get the correct photonic absorption. All right. Do I recommend lipid peroxidase urine test to measure heart attack risk? Yes, this test I do on every single patient. The urine microalbumin creatinine ratio is a rough estimate of your glycocalyx function. If you're leaking protein in urine, that's bad. But a urine test that looks at F2 isoprostanes over your creatinine ratio is a very good marker of your oxidative stress. This is what I tell patients, it's a marker of how likely you are to rust from the inside out, heavily influenced by your exercise and nutrition choices. So if you have high F2 prostate and creatinine, you have high oxidative stress. If you have high oxidative stress, it may lead to more inflammation. It may damage the glycocalyx. If you damage that gel coat in the artery, the glycocalyx, you're set up to developing plaque in your arteries. So I do measure it in all patients. Next question. Vascanox versus NO2U, same or different in mechanism, efficacy for NO support. So these are two nitric oxide promoting supplements. I've used them both personally. I've had patients use them. They work a little bit differently, where NO2U is a orally disintegrating lozenge, where Vascanox is a capsule. NO2U generally is taken 1 tab twice a day. Some people can get away with using 1 tab a day if they have better nitric oxide stores without having to take it twice a day because they're exercising, they're getting their nitrates in their diet, or they're outside in the sun appropriately. And Vascanox is a once-a-day product. Vascanox also helps promote hydrogen sulfide, which is a vasodilating gas as well. Kind of acts like the phosphodiesterase inhibitors, and it keeps nitric oxide around longer. So similar mechanisms, slightly different durations of action. Both can be beneficial. Some people prefer one form over the other. It's a test, don't guess type of situation. I've seen some patients not necessarily respond as well to the orally disintegrating lozenges, so transfer them over to capsules, and then sometimes their pulse wave velocity, their endopads, their other testing are looking better on that. So I use whatever works for the patient. And then just disclaimer, I do speak for Calroy on occasion for some webinars and teach other doctors about vascular health, and I personally use the product. All right, next question. How do you get comfortable with newer drugs when long-term impacts are not really known? Great question. It always depends on the drug. Unless it is an absolute life-saving drug, I usually will wait a little bit before making that recommendation. I had a wise attending once when I was in my training said, don't be the first doctor to use a medication and don't be the last one. So often there are not, game-changing medications, that there are no alternatives. So we'll want to see, a couple million patients in the real world getting these things, looking for real-world side effects, not just the ones reported in trials before sometimes I'll switch some people. But it depends on what the drug is treating, and the risk that it's going to be lowering. So I educate myself pretty well. I try to stay at the tip of the spear on this stuff. And if there's something that doesn't make sense, I'll pause for a while and wait. But if something's really, promising and lower risk, then I will, recommend it to my patients. But it's always based off the context that I know their story. Question: are there any harms to taking nitric oxide supplementation if blood pressure is good and no circulation issues noted? I can't give direct medical advice in this case, but in generality, if you have normal blood pressure or normal vascular health markers, you may not need nitric oxide promoters. Most of the time, if you take nitric oxide promoters, it's not necessarily going to lower your blood pressure too low past your normal set point, but if you're getting lightheaded or dizzy with these type of products, definitely need to back off of them or stop them. But talk to your doctor or the person who recommended that you take them first point. Question: what is better for arterial health, berberine, arterisol, or garlic? I don't know if one would be necessarily better than the other. I often use all three in combination. Berberine is kind of like metformin, helps with blood sugar regulation, but it's also a weak PCSK9 inhibitor, so it can help with lipid modulation. Arterisol is a glycocalyx promoter that helps regenerate the glycocalyx. So if you help the glycocalyx repair, you don't have as much inflammation in the artery lining, you tend to be able to stabilize plaque, may get plaque to regress. And then Kylo garlic, similar story, stabilizes plaque, it's anti-inflammatory. So sometimes we use all three in combination. Can you take berberine long term? Generally, yes. I typically don't use more than 500 milligrams twice a day. Now, there's other protocols that have higher doses for certain gut protocols. From fungal infections. I don't know the data on that because I don't treat those indications in my practice, but the lower doses, I've not seen any concerns. Question: my coronary arteries are left dominant. Does that pose any risk? They're 63 years old. No, that's a normal variant. 80% of people's coronary arteries are right dominant. This just means that the the posterior descending artery comes off the left circumflex versus the right coronary artery, no, there's no particular risk associated with that. It's something that's noted when you get a CT angiogram or a coronary angiogram and then see where that artery is coming off of. And then next question, somebody's saying, can I respond to Ben Bickman's post about higher LDL correlating with longevity? So first off, I don't know who this gentleman is, so I don't know where to find this post. So if you submitted this question and you can DM me some more information about it, I'll try to respond to it directly. But this is one of the cases where, you have to kind of look at, the whole totality of what's going on. If somebody has high LDL at a certain age, what does that mean? Well, I always wonder, what do the arteries do with that information? LDL is part of the immune system. So, at certain points, it is beneficial. But after the age of 40, at certain levels, you're more likely to get atherosclerosis, which could potentially shorten your life. So I don't think it's so black and white that, high LDL is, quote, bad for you always, or that it's going to be promoting longevity always. You have to look at that individual who's sitting in front of you. All right. Those are the pre-submitted questions from the other night, so welcome to everybody else who's joining. I know I got a few other questions that just popped up earlier today when I put this in my story, and so I'll hit those ones now. So these may pop up across the bottom of the screen. So somebody's asking about antiphospholipid antibody syndrome diagnosis. Is it possible to get off rivaroxaban, or is it a life sentence? So again, this can't be medical advice. It has to be the person who's put you on these medications, to decide if it's something they potentially can wean off you. I did participate with a patient in a documentary called Uninflame Me. Angela had put this documentary together on her own health journey. Uninflame Me is actually on Amazon if you're interested in watching it. It's a few years old. I look a little bit younger, had a little bit different information at the time. Didn't know about circadian biology, so I'm not wearing the glasses. And I wasn't really talking about quantum biology at the point because I didn't know it. So I know a little bit more than I did in that documentary if you go back and watch it. But she had a autoimmune condition that she helped reverse by getting off some of the things that were driving her inflammation, and was ultimately able to come off anticoagulation. But you have to reverse the autoimmune condition and then work with somebody who understands that that's possible, and then it is potential. But you have to work directly with that person. You can't stop this stuff on your own because otherwise the risk of blood clots may be too high. All right. Question. If I had a calcium score of 0 at 28 years old, they're now 32 years old, when should I retest? Well, a calcium score of 28 would be very unusual to be above 0. It usually takes a little bit before the plaques will calcify. So first we want to know, why did you go off and get a calcium score at under 30 years old? That's not very common. If you have a strong family history, generally we'll screen people 10 years before their parents or their family members had vascular disease. So I'm kind of changed my own practice patterns to say probably 35 is a good starting point for a calcium score. And most people are at high risk, but still you're fully expecting these scans still to be 0. So I would contemplate doing a CT angiogram, and ideally with a clearly analysis, you can actually look for soft plaque in the arterial walls. That is going to be more sensitive for a younger individual. Now, if you're just going to be able to follow calcium scores, then generally every 3 to 5 years, if your score is 0. If your score is greater than 0, I wouldn't repeat it. You're already higher risk, and start treating what's going on. So that's what I would consider. Question from one of my colleagues, somebody asking about a max pulse, which is a pulse wave velocity testing. It's showing a level 4. Anything I recommend besides lifestyle changes? So the max pulse is a finger probe. It's measuring the speed of the blood going into the arteries, how fast they expand, and how fast they snap back. The lower the score, the more elastic the artery. So score 1 and 2 are normal. And the higher the score, the more stiff the artery. So 6, 7, they're very ill or sick arteries. So level 4 is kind of in the check engine light. Of course, lifestyle recommendations always, are kind of baseline. Make sure they're, managing their stress, they're sleeping well, they're exercising, they're eating a reasonable, whole food type of diet. And then looking at things that potentially affect it, Are they doing things that break their nitric oxide pathways? Are they using mouthwash? Are they on proton pump inhibitors or H2 blockers? And then looking at biomarkers, do they have a ton of oxidative stress and inflammation? If they do, fix that, and then the max pulse likely improves. Often you got to support nitric oxide. Question, anything specific that should be done to help improve the stenosis? So I don't know if this is still tied into the max pulse question. On the report, it looks like there's blockages in the artery when it's, it's type 4. That is just a representation of, people who have stiffer arteries may have more atherosclerosis, so it doesn't mean that there's necessarily stenosis. You have to do a carotid intramedullary thickness scan or a calcium score or a Clearly scan to really know do they have stenosis. And then it's the similar story, do what you need to do to improve nitric oxide availability, support the glycocalyx with products like Arteriosil, use whatever lifestyle supplement medications you need to keep oxidative stress and inflammation low, and then ideally keep ApoB under 70 through whatever combination of nutraceuticals, pharmaceuticals you need to use. Next question up. Is there ever a time where lower is not always better? So that core is a device that measures your brachial blood pressure, so that's the blood pressure in your arms, but also assesses your central aortic blood pressure. So the blood pressure as it comes out of your heart and goes down, as it goes down your heart arteries, and as the blood pressure goes up to your carotid arteries, up to your brain. So the central blood pressures are the vital blood pressures to your organs. So if your pressures are low and you're asymptomatic, probably not much to do about it. But if the person is lightheaded, dizzy, exercise intolerance, passing out, well, if they're on antihypertensives, you need to back off on the antihypertensives. If they're on any supplements that are, boosting nitric oxide, you're probably going to have to back off on those supplements as well. If they're not on any supplements or medications and they're still having low blood pressure, then you're worried about their adrenals, and they may need to get a further workup for that. Rarely does people need midodrine to raise their blood pressure. And then I think I answered this question. Somebody's asking, does building more muscle decrease LDL particle numbers? Not in my experience. It definitely helps with keeping triglycerides controlled, but not necessarily the particles themselves. But it's always good to have, there's no magic number on lean muscle mass. Probably more is better for most people, because most people don't actually try to maintain their muscle mass as well as they should. But it doesn't have a major effect on particle number in my experience. All right. And I've seen a few things pop up in the comments from people, so welcome. This is a question. Doctor, I see a lot of athletes and fit people that get heart attacks while training. Should I stop training? I can't answer this without more context, and also I can't answer this unless you're my patient. So you have to talk to your actual, healthcare team before making that decision. But it's one of those cases. Test, don't guess. Or another way to say it is, I'm from Missouri. You have to show me. Do you actually have healthy vascular system? Just because you're fit on the outside does not mean you're necessarily healthy from the inside out. So you have to go looking at the arteries with testing. It looks at endothelial function, looks for vascular inflammation, looks for soft plaque, looks for hard plaque. If those aren't evident, okay, great. Sometimes patients who are very fit have events because they have hypertrophic cardiomyopathy, or they got anomalous coronary arteries. So there's other reasons why people have events while training. It's just the high heart rate tends to unmask those type of conditions. So you need to work with your doctors to figure out what level of exercise is safe for you. Person's a 24-year-old man on valsartan, which is an angiotensin receptor blocker, and amlodipine, which is a calcium channel blocker for their high blood pressure. Is it normal to continue on them for the rest of my life? Again, would need more context. 24 is often awful young to be on blood pressure medications, but not unheard of. Especially if people have a large genetic preload. Mom, dad, grandma, grandpa all had high blood pressure, been more common. But you generally can get to the root cause why people have high blood pressure if you do the right analysis. So in my practice, I often do a test from Cardiac X from Vibrant America. Looks at 20, 30 different genes that affect hypertension, and then you can figure out what lifestyle intervention, what supplements, what nutrients, and then if they need to be on medications, which ones are likely to work better for them. But I always look at it first is that, the arteries are just responding to some type of insult. So, you'd have to show me that you have healthy nitric oxide levels, no oxidative stress, no inflammation, no high oxidized LDL. Then we get to work on, okay, how do we work on getting off these medications if that is your goal? Question, what do I think about fucoidan as a supplement for the glycocalyx? It is a possible benefit. It depends which product particularly you're speaking of, because there's a couple that have fucoidan. Some have more research than others. So I always like to see clinical trials that were done ideally in humans that were using some type of testing that looks at the vascular health and is not just a theoretical study that looks at just animal data or just looks at different biomarkers. I want to see, do the arteries actually get better with these type of things? Question, can you have endothelial dysfunction and be a high producer of nitric oxide as shown on an oral test strip? Is it protective, or does the dysfunction overrule any protective nitric oxide benefit? Great question. So the lining of the arteries, the endothelium, releases nitric oxide. But after the age of 40, this pathway tends to slow down as the endothelial nitric oxide synthase enzyme doesn't work as efficiently. So a backup pathway is that you can make nitric oxide through your salivary pathway if you have the right oral nitrate reducing bacteria and you're getting the proper levels of nitrates in your diet to do that conversion. So if you have a test strip that's positive, that's a good starting point. But the health of the arteries, by testing, pulse wave velocity, an endopat, the central blood pressures, if those are abnormal, those trump any oral test strip. So you want to have that pathway working well, but it's not enough. Somebody says, lots of Kyloic garlic brands out there. Do you recommend one over the other? If not, what should we look for when purchasing? So Kyloic garlic is a brand name. There are other garlic products on the market, but it's mostly been Kyloic that has been studied. They did a lot of studies at UCLA looking at Kyloic garlic in patients with elevated calcium scores. Now there's different versions of Kyloic garlic. I tend to use either the green bottle or the gold bottle. I don't need a lot of the other add-ons, and I try to go for just the straight Kyloic garlic. This is a question that I can't answer directly because I can't give one-on-one medical advice unless you're my patient. Somebody said that they're taking ezetimibe 5 milligrams and it dropped their ApoB relatively significantly, but they're having some side effects. Can they take 2.5 milligrams instead, and is it going to work? It just was not studied at that dose. The standard dose of ezetimibe is 10 milligrams a day. I believe there are some studies where they looked at 5 milligrams, but I've never seen any at 2.5 milligrams, so it would be unknown if it's going to work. So you'd have to work with your doctor to see, are they comfortable having you do a trial at a dose that's not been studied, and then repeating labs to see, did it keep your ApoB at the goal that they're shooting for, or do they recommend you switch to something different if you're having side effects? And that's usually what I recommend is, people can't tolerate something. I'm never telling them they have to take something. We'll always try to find an alternative for them. All right. And somebody sent me some nice feedback. They like my YouTube video, my Cleveland Heart Lab panel results, and thought it was awesome. Well, you're very welcome. That was something that I just put up on my YouTube channel earlier in the week. I'll be shooting another one in the relatively near future and showing you the differences from my previous results after I did some interventions. I will also be sharing my Clearly results on there at some point. I just haven't had time to sit down and record that video, but the too long don't read is that I was able to get the soft plaque that I had on my Clearly analysis to decrease by 6% in less than 3 years, which is remarkable because usually plaque does not go down that much. And I was not on any pharmaceutical agents at that moment. since have started something because I want to try to be a little more aggressive with it, but I will share that on that site. So it's just my YouTube channel, at Dr. Twyman, but if you want to go to the website to go there, just drtwyman.tv. It just forwards on to my YouTube channel. All right, so I think I'll answer this last question, and then I'll let you guys get on with the rest of your day. So, is it better to work out around solar noon or in the morning a couple hours after sunrise? Depends on what your goals are. If it's just, I got to get it done because I have no other times of the day, then yes, do it earlier in the day. But from a musculoskeletal standpoint, your body would optimize for peak performance in the mid-afternoon. So there's a very useful app called the Circadian app. If you download that app, it tells you where your location is, when the sun's rising, when UVA comes out, when UVB comes out, when those wavelengths disappear. And it also gives you an idea of when would be the best time to exercise. So the Circadian app would be my recommendation for that. So I appreciate your guys' time and attention today. If you enjoyed this type of content, please send me some feedback. I always appreciate it, and I always try to make these things better for you guys when I can. I'll keep doing these every Monday night, 6 p.m. Central Time. And for those people that are local or in my practice, August the 2nd is going to be our celebration of our 5th anniversary of having Apollo Cardiology launched in St. Louis, Missouri, where we focus on the early detection of vascular disease and help people not have heart attacks or strokes. Now, I was an invasive cardiologist for many years, treated many, many heart attacks. I thought it was a better idea to prevent them than to have to treat them. So if you're interested in that type of work and potentially want to work with us, I do have a waiting list right now because I work with patients from all over the United States. Approximately 40% of my patients come from out of the St. Louis area. Go to my website, just drtwyman.com, and there's an application in the top corner. One of the members of my team will reach out to you, set up an onboarding call, and if it makes sense for you to come to see us, we'll get you all squared away to come work with us. So have a great rest of the afternoon, guys, and we'll see you next Monday.